This week on the BackTable podcast.
It starts off with just a history where I sit back and I listen to their story so I have a better idea of what they're looking for. Are we having heavy bleeding? Are we having pelvic pressure issues? Mass effector bleeding. I go through about their fertility history or fertility desires, and through the whole history about like medical and surgical history, like what are we getting into? Is this somebody who's had 8 prior laparotomies and they have a uterus with a 1.5 centimeter myoma that's in the inner lining of the uterus? Or, there are so many factors to consider. If you have a really big uterus and you have fibroids and you're looking for hysterectomy and you start moving towards that direction, I definitely want to do some basic evaluation beyond the history, like a good old-fashioned physical exam, because very often by the time they come to see me, they want to know how this is going to happen.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got a good friend with me today, Uchenna. How are you, man?
I'm doing very well. Thank you, Mark. Thanks for having me here.
Thanks for finally coming on. We've been talking about this for a while. It's always good to have our friends come and hang out with us on the show, and you are one of my nearest and dearest, what do we call, conference buddies.
Absolutely.
It's just not AGL unless you and I are walking like 20,000 steps in whatever town they put us in.
For years.
So it's an absolute pleasure to have you on. Uchenna is an assistant professor of OBGYN at the Donald and Barbara Zucker School of Medicine at Hofstra/Northwell. He's the chief of minimally invasive gynecologic surgery at Northwell Health and the program director of the FMIGS fellowship up there. I know that's been an exciting thing for you, being fellowship director, and your fellows are very, very lucky to get to train with you. And we're going to talk about one of the reasons why here today when we talk about tackling the big uterus. This is something that I think I just talked to one of my friends at work today about a case that she's doing, and she's like, yeah, it's like a 10 centimeter fibroid. It was someone who's not as far out and not as didn't do an FMIGS fellowship, but was like, I think we can do it. And in my mind, one of the residents is with us, and she looks at me and kind of laughs because she knows what's your cutoff? You're like, I don't know what that means. So as we're getting started here, we like to have our listeners hear from our guests. So who are you? Tell us a little bit about yourself, how you got to be where you are in your professional life now.
Again, thank you for having me here. You covered all the big points. I'm at Northwell Health. I specialize in minimally invasive gynecologic surgery at Long Island Jewish Medical Center, where I'm the chief of our division, and I'm the program director for the fellowship. I've been out of my own fellowship for, I think it's been about 11 years now. And in that time, I've been doing a lot of minimally invasive surgery, learning new techniques, trying to deliver excellent healthcare to our patients in a way that'll get them back on their feet as soon as possible. And that's really what my practice is. It's a referral practice for people who need some sort of intervention for advanced gynecological surgery.
Northwell's a big hospital system, yeah? It's all over, mostly Long Island, or where are all the hospitals located?
Yeah, Northwell is huge and ever expanding. So people know about North Shore and LIJ, but it extends out further east in Long Island, down to Staten Island, into Manhattan with hospitals like Lenox Hill and Meath, up to Westchester, and really ever growing.
Oh, wow.
It's a huge catchment.
So is there an incentive to refer patients within the system? Is that how you build like a subspecialty surgical practice? Because you and I have talked for years. It's been, it's a challenge to build a subspecialty referral practice without that referral base. Is that kind of built into where you are? Is that something that takes a while to build where you are?
Yeah, I think it does take a little while, but where we are, we're kind of fortunate in that we do have such a large catchment. And as you know, when it comes to minimally invasive surgery, obstetrics really drives your gynecologic volume. So Northwell delivers 1% of the babies born in the country. It's a ridiculous number. But with those pregnancies come fibroids and adnexal masses and endometriosis. And so that's really how we get our volume. It's just from need from the OB community.
Oh, wow. It's huge. Well, you and I mean, one of the things that I know we love to do besides go out to fun restaurants while we're traveling. It's going to talk about our practices and sort of, each year, because I've been out, I guess this is my end of my 12th year since fellowship. So we've had a similar length of our attending careers. And so as we're both, and I think our patients would love to hear that we come out, as my chair says, like seasoned, like ready to go, like teed up and the best we've ever been the minute we start. And we know I won't speak for you. That wasn't true for me. And so I love the opportunity to go on walks with you and kind of talk through the challenging things that I was experiencing and kind of run it by you, and super grateful for that opportunity, and something that has helped me over the years a great deal.
Yeah, I think the first step is just recognizing that education for self doesn't end at graduation. It really doesn't. And yeah, you and I have spoken through some tough cases and some general terms, general scenarios. And
career stuff too, non-clinical stuff. I mean, you just got your MBA, right?
Mm-hmm.
Where were you when I called you? Was it Portugal or something? What was?
Probably, yeah, in Portugal for the near the end for our global. It was really just the end. It was a culmination of the master's program for the MBA, and we were basically consulting for a couple of companies in Spain and Portugal.
Oh my goodness!
Nothing to do with medicine.
Well, it does though, right? I'm sure you brought a lot of that back, I assume, and that's one of the things I think about. I think I need to get my MBA, and I've talked about it a little bit on the show. I've talked to you about it quite a bit, but is it, professional healthcare MBA versus an executive MBA program that's for physicians? Do you do non-clinical? And there's just so many different opinions about it versus like, oh, you've already, because I'm a CMO now, it's like, you're already doing it. Like you're doing your own version of that, which I actually don't. I think I have a lot more to learn. And so I think that's in my future. But yeah, we've had a lot of time to sort of grow up together in that sense clinically. And I think one of the things we talked a lot about was like just tough cases. And so one of the things we were in Las Vegas recently together and being able to think about interesting things to talk about. I think one of the things my residents always say whenever I'm operating with them is like, just always talk about how the size, the big uterus is tackling that big giant uterus. And that's something I think that a lot of us makes folks do a lot. So talk to me about just like your practice in terms of like how you counsel patients and things like that and what kind of referrals you're getting. And let's talk hysterectomy. I think myomectomy we can save for another show, but for hysterectomy, like how do you approach that patient that's got a big uterus?
So in my practice, it's generally a consultant practice. So patients come to see me and they're not surprised to hear me say the word hysterectomy. They're not surprised that they might need that kind of procedure. So that's a huge hurdle right there. Many of these patients have gone through where they discover fibroids. Perhaps it's years ago. Perhaps it's just in that recent moment where, the story about how the woman finally comes in because she got tired of people giving up their seat for her on the bus, because they thought she was pregnant and she didn't realize it. So there are some life changes that kind of open people's eyes and give them the idea that they need some sort of intervention. And then there are people who just follow. They have fibroids, they just follow, they tolerate, they make do with the heavy bleeding, the pelvic pain and the pressure, etc. And then at some point they've had enough. And, you and I have spoken about this, people have that moment where they come to the decision. So when they do come to the decision, in an area where I am, there are plenty of surgeons around. And for many people, you go in and your generalist will talk to you about the next step, which is going to be surgery. And depending on a lot of factors, the approach may be an open procedure or it may be a more minimally invasive procedure. I found that very often patients are more savvy than they were maybe 20 years ago, and they will say, oh, okay, I understand that I need this procedure. Can I have this in a way that'll help me get back on my feet sooner? That's where you and I come in. We also have a bunch of providers around who will say, okay, you really should have this procedure done. My training is not in doing this in an invasive way, but I know somebody, yes, in our system, in your geographic area, whatever it is, who can take care of this and help you get to the place where you want to be in a shorter period of time.
So do you feel like patients, and you said this, are more savvy? Do you feel like their expectations are a little different? Because in my experience, especially when I first started, one of the things that's unique about OBGYN is that, if you're have a kidney problem and you see your nephrologist and they think you need surgery, they send you to the urologist, and the cardiologist sends a patient to cardiothoracic surgeon and so forth. An OBGYN is the one who can make the diagnosis, but also is the one that can potentially do the surgery. And so they're referring something away from themselves, which is a unique, I think, situation in medicine, in healthcare, that if someone has a patient with a big uterus and it's like, well, I could do it open, but if I wanted to make sure they had a better opportunity for a minimally invasive approach, I'd have to send them to someone else. And we know that medicine's a business, and we know that, we want to assume that all of our docs are doing the right thing. And I don't think it's a bad thing to say, like, you can do with me, I can't do it laparoscopically, if you want to open. And a lot of times patients just want their doctor to do it, which is totally appropriate and totally great. But there is kind of that, like, how much are you going to push a patient away? And so do you think patients are becoming more savvy in your experience, in your time, and also in your geographic location?
I really do. I think so, because there's definitely more information on the internet, and people are getting better at navigating through it to finding real data. And then the patient network, which is, oh, my aunt has fibroids and she had it taken care of this way, or my aunt needed a hysterectomy, and so there is some validity to that. I don't think it's wrong. And I think that part of being savvy is that you can then go to your own doctor and say, okay, I hear what you're saying. Is this an option? And most of us are going to look into it, and whether it's specifically something that we can do or cannot do, we'll look into it and try to find the best way to treat that patient. I mean, to this day, you and I refer patients out for other reasons. If somebody has an unfortunate diagnosis of cancer, and we know it beforehand, we might refer them to a GYN oncologist. Some of us will refer patients out if they have special needs from a urogynecologist to help with pelvic floor support. And it's just an evolving process.
And I don't do a lot of TVH. My partners do, the urogynes. So send them across the hall, like, right patient, right surgeon, right location. Like, that's our job. The way we think, I think that's how most of our colleagues think. I think that's how most of our patients are now understanding that that's how it can be. Because I think back in the day, it was like your OBGYN came in all hours to deliver your baby, and it was the same person all the way through. And now, because people have become more sane and more reasonable, and they share practice and share a call, and that expectation is not like it used to be, I think that allows and makes it a little bit easier to say, well, then I'll have someone else do my surgery later on too. But when a patient comes to see you with a big uterus, or is referred to you for a big uterus, talk to me about your process and evaluation, counseling, expectations, that kind of stuff.
So it starts off with just a history, where I sit back and I listen to their story, so I have a better idea of what they're looking for. Are we having heavy bleeding? Are we having pelvic pressure issues? Mass effector bleeding. I go through about their fertility history or fertility desires, and through the whole history about, like, medical and surgical history, like, what are we getting into? Is this somebody who's had 8 prior laparotomies and they have a uterus with a 1.5 centimeter myoma that's, in the inner lining of the uterus? Or, there are so many factors to consider. If you have a really big uterus and you have fibroids and you're looking for hysterectomy and you start moving towards that direction, I definitely want to do some basic evaluation beyond the history, like a good old-fashioned physical exam, because very often by the time they come to see me, they want to know how this is going to happen. So physical exam will give me the information about whether I'm offering a vaginal approach, a laparoscopic approach, or an open approach of some sort.
What percentage of your cases would you estimate are vaginal versus laparoscopic or robotic? Are you doing robotic at all?
I'm doing robotic. I'm also doing V-notes cases, so the vaginal natural orifice. And I'll tell you that my vaginal hysterectomy numbers have probably decreased a little bit because I'm doing more V-notes cases. And so I've converted some of my laparoscopic cases into V-notes cases.
How do you like it?
You know what? I think that there is a role because I'm doing more vaginal surgery. In the end, that's what it comes down to. So these are women who are leaving with no incisions on their belly. Everything is through the vagina. I am comfortable doing the V-notes procedure because one of the downsides was being able to evaluate the adnexa. And when I can do that with a scope to bring it up to, half a centimeter away from the ovaries and from the fallopian tubes, and I can remove them easily, that's given me some comfort. That's given me a little bit more of confidence to take that approach from below.
But you were doing TVHs as part of your practice as it was.
I was, but not very commonly.
It's just, I was trained in somewhere at a place where they had a lot of urogyne presence or a strong urogyne presence. We I came to, my job here where they had urogyns, and it was like, well, I can just send them over, and I was doing the complex lab stuff. So my comfort level wasn't there. And once I got started and got busy, it was really hard to go back and sort of get comfortable. And now we've got 2 really good urogyn partners who do tons of vaginal surgery. And it's like, I just haven't gotten back on that horse. And it's almost like, how much do I want to invest in doing it? And so I haven't done it. And we had Jan on the show come and talk to us about B-Notes. And so it seemed like an amazing approach. And I did the training and all that stuff. I just haven't gotten back on that horse. Are you offering this for like tougher cases, or still, how many have you done? Are you doing tons?
I've probably done a dozen, not a lot. But what I've done is expand the offering. So the patient who has 2 prior C-sections, I wouldn't have even attempted that vaginally. Yes, I know it can be done via straight vag hyst with 2 prior C-sections, but I wouldn't have done it. But with the venous procedure, where I can go in with the camera and carefully dissect through some of that scar tissue, it's...
Some of the videos that I watched that made it almost look easier than, or as easy as doing it laparoscopically. So
it definitely keeps my heart rate down.
Let's talk about, though, the big uterus that comes in. Do you have a limit? Do you have talk to me about your process.
Yeah. So people always ask, and it's not an absolute. It's not like, okay, if it is 15 centimeters, I can do it laparoscopically. If it's 16, well, then we're going to have to open. There are factors that go into it. Yes, prior surgeries, et cetera, but also the relationship, as in the size of the uterus to the size of the person. So I found that if I have somebody who has a 16 centimeter uterus with fibroids and she's 4'11", 107 pounds, that's going to be maybe a challenge because there isn't a whole lot of room to operate. And so I remember I can picture the patient where after the case, doing an open case, I go, you know what? That was probably the right thing to do, because laparoscopically, I don't know if that would have been in her best interest. I think it would have been a challenge. So that's something that I factor in. That's why the physical exam is so important to me. Conversely, is true. You're 6'2", you have a 20 centimeter uterus.
You've had 4 kids.
Yeah.
Your belly's been stretched. We're going to fill up your belly. It's going to give us a wide view of things.
Mm-hmm.
We're going to get a much better dome in which to operate.
Yeah. And I'm thinking about access to the blood supply. I'm thinking about being able to secure mostly the uterine arteries. And so on my physical exam, as I move the uterus around, I'm thinking about how wide is the cervix, how mobile is the cervix, how much space is there, in the next end. That's going to give me the confidence to say, okay, we have a good chance of doing this laparoscopically.
The pelvic is, to me, like the pelvic exam is like where you go, okay, in my mind, the case is done, right? Like you're moving it up and down. You get, okay, push it up and over this way, up and over that way. If I can kind of get a hand between their ASIS and their, and their low uterine segment, well, then I can get my instruments in there. It's not always palpable in all of our patients. We like to be able to say we can always feel it. But in general, I can usually, even in larger patients, there's usually a space in there to feel and go, okay, I can be pretty confident that I can get it. But even still, though, I think even sometimes when you got a low cervical fibroid or something that's real low and bulky, at the end of the day, though, a lot of times you can take those upper pedicles and everything just eventually everything kind of pulls up. But yeah, I think I've also had a couple of patients that came to me because they were referred because, oh yeah, he does laparoscopic hysterectomy for bigger uteruses. And a couple that I saw in the middle of my career, luckily it was not right out of fellowship, but they came to me and said, hey, listen, I really want this done laparoscopically. And you look at them and it looks like they're carrying a term pregnancy. And you're going, well, I think this is probably a bad idea. And they said, I hear what you're saying, but I want you to try. And I said, well, okay, but the odds are very high that we're going to put a scope in or get started. And certainly, we think about complication rates are the highest in those conversions. And I'm just letting you know that this is not what I would necessarily say would be my first choice, but I'm not going to be paternalistic here. I'll listen to you. I'll tell you that I'm not going to be unsafe, and we'll take it step by step. And the craziest cases, some of the craziest cases I've done where patients said, listen, we'll just try it. And, what's the biggest uterus you've taken out laparoscopically?
It's probably about 2,700 grams. It was a good size uterus. And it was a situation where somebody said, I know you're going to end up opening, but can you just try? And I was like, I can put a scope in. I can make sure it's not, slam dunk that we're going to miss. And then we'll see. And you put a scope in. And I remember going, okay, well, you know what? We're going to take the rounds. Oh, look how much it's moving now. There are the uterines. And all of a sudden, You've got a devascularized, huge mass. The rest is academic.
That's it. No, I think so. We do 2,500. I wouldn't say regularly, but I'll do a few of those a year. We had, again, and a lot of it's just the anatomy too, right? So I had a relatively tall, healthy person who came in with a term size uterus, and there's no bag de like that, right? So you gotta talk about that, which we can talk about a little bit later. But end of the case, we pulled it out, and it was 2 buckets. It was massive, buckets full of uterine pieces. And then I saw the uterine weight on path, and I was like, 2,500 grams. That seemed like a lot bigger than that. And then I saw that was specimen 1. The other specimen was 3,500 grams. It's a 6 kilo uterus, 13 pounds, which I hope to never do again. But again, it was all fundal. So once she was upside down and you got the upper pedicles, the uterus falls up to her diaphragm, and you've got not quite a normal hyst, but uterines and coke up and all that. Like, it's a lot of the same steps. She'd not had a bunch of prior surgery, right? There's so many things that allow us to do these cases that, we like to make ourselves feel good, but a lot of times it's just the patient sort of presents in a way that allows you to do it, not the other way around, because you've had a few. But I think I've done, like 5 hysts in 12 years that are abdominal. I've done, I think, 99% of my hysts laparoscopically, 0% vaginal though, which is not great either. So, and I've referred some out. There's definitely somewhere, BMI of 65 or 70 and then go to ONC. So my numbers are certainly cooked a little bit, which I'm not ashamed to say, but they're also, again, right patient, right hands, right place. So, all right. So you do an exam, move the uterus around, feel pretty good about it. You can sort of visualize it. Do you do that at all? Like in your mind, like kind of go through the case, like because you're an athlete. Our listeners don't know you are a star lacrosse player.
In my mind, that is correct.
Visualizing yourself as a star lacrosse player, but at least your kids have a chance because your wife, right? That at least gives them
right.
half a chance. If your genes aren't too dominant, maybe that they have a chance as being athletes. But yeah, so like for me, it's like, okay, I can see how this is possible in my mind. Then I feel like I can do it. All right, so you've made the decision. Okay, I'm gonna do this laparoscopically. If big uteruses, you using the robot or using straight stick?
Mostly straight stick. I like the option to move my scope around, move my instrument around. 4 ports is common. 5 ports is fine. 6 ports if necessary, and that a 5 millimeter port.
Fives are free.
That's what
the general surgeons tell me.
Yep.
Fives are free. Do you use only 5s for all your cases? 5s.
The most important adjustment I made was getting comfortable starting up high. So going into the left upper quadrant, and I've done this with my trainees. Okay, you're in the umbilicus, you see this fibroid, it's in your face. The uterus is there, and it looks intimidating. You go 5 centimeters up north, put the scope in, and all of a sudden, you see a little sunlight around the edges. And so I think that was an important addition to my practice, just moving north.
I'm trying to remember how much Palmer's Point we use in fellowship. I mean, I think where I train now, they do it a little different, but Varus needle in the left upper quadrant to me is like home run every time. I mean, it's just like the safest place to go in someone's belly for me, in my hands. I think umbilicus, cosmetically, if we're going to, try to save an incision in someone who's getting like a tubal or something and avoid. But if they've had prior surgery, what are when do you go belly button? When do you go Palmer's? And are you doing direct entry or Varus?
I'm doing Varus. That's what I was trained. That's what I'm comfortable with. And I believe, right patient, right location on the body, right technique. And I think that, you can do it safely. I try umbilicus, but when you're talking about the big uterus, I don't bother in the umbilicus. It's just not worth it. I'll go up high, do the survey. I may add an umbilical trocar to help manipulate the lower part of the uterus, but my camera ports are going to be up high. Usually one on the left side, one on the right side.
I think having that Palmer's Point port allows you to plan visually. And like, yes, we can feel and we can do our exam and we can plan that way. And, you can put your markers on the patient or whatever. But the reality is until the abdomen is insufflated and stretched out, until I have a view of the uterus and see where the rounds are, because you can have the rounds real low and the fibroids all bulky above that. The rounds are stretched all the way up into the upper left, right. You can all the permutations you can imagine. So where those IPs are being pulled up to, where the uterovarians are. Like, I need to kind of see it if I'm going to place my ports optimally. But once you've placed your ports, you've got, okay, here's where I'm getting set up to go. Are you always arms tucked, always lithotomy, uterine manipulator, always in every case? What do you guys use up there?
I'm using the Delineator by Cooper Surgical. It has a nice cup, and it has the vaginal occluder balloon.
We got the V-Care for a while, and because of resident coverage and things like that, they let us get an Ally uterine positioning system, which you got to use one of the Cooper manipulators. So we'll get, I think, the Vincula Arch with that one, or whatever the Delineator you're talking about. But yeah, I like that cup. I trained with a cup like that and had to kind of get used to the V-Care, but same idea. But okay, so always manipulator. And then talk to me about if you can't get the manipulator in at the beginning of the case. Has there ever been a case you couldn't?
Yeah, and I can remember a couple of cases where people have had cervical pathology and excisional procedures, multiple excisional procedures, can't find the os, and somebody's down there. Usually it's before second year, struggling, trying to get down there, and we'll send the fellow down there. And then if it's not going to happen, then just let it go and start the case. The uterine manipulator is great for manipulating uterus, but it's not the only way. So if I have to then, let's say, put another trocar in, whether it's in the umbilicus or suprapubic, to manipulate, I'll do that. The next place I like the manipulator is for the colpotomy. And so I may end up, and I've done this a few times, where I'll take the uterines low, do a supracervical hysterectomy, and then place a uterine manipulator.
Oh,
and there are
smart.
some different fun ways to try to do that. I like to...
Top down, you could put probably just like your DeBakey or whatever in through the top down to put your finger in there and find it that way.
I could do that, yep. I now take I take a needle nose instrument, take a suture like a 0 proline, put it in from the above, pass it all the way down, tie the tip around the tip of the manipulator,
yeah,
and pull it back up. Yeah,
I'm guessing this is like when you're tinkering around the house trying to fix your, something in the garage. This is like the kind of stuff we come up with here.
It's like 3:00 in the morning, laying in bed, going, "Oh, what about this?"
Oh, that's how I came up with my 2-port tubal. This is my, we sent a video to AGL. I think they didn't take it last year, but just an umbilical and suprapubic port to do a self-injectomy. And if you've done that, you can get the uterus up real high, and then take your ligature or whatever device you're using, starting at the cornua and down. But then when you get close to the fimbria, it kind of pushes into the pelvic floor. And so I put an endo loop on the cornua of the tube, and then pull the string out the suprapubic port and put the instrument back down there, and it sort of pulls it right up into the...
That's good.
I was like, I think this is going to work, because I didn't have a resident, and it was just me and the tech, and she's like, I think she said, that was slick as snot, was what she said when we did it. It was very cool looking, but umbilical and suprapubic port, both hidden, I think patients like that. But okay, so manipulator every time when we can. I wouldn't say I'm dependent, but I definitely, it just to me is like, when I see people not using them or like not really making the effort to get it in, I'm like, this is like, it's such a helpful thing on a TLH, mostly for what you said, for the uterines, for the colpotomy. Like, the upper stuff doesn't matter too much, especially in the bigger pathology. But what's your first move with a big uterus? What's the first step? What's the first cut?
So it really depends on the round ligaments. How much mobility do I have? And if I don't have a lot of mobility, is it because of the mass, like just pressure? But I find that very often it's because the round ligaments are just tight. So I transect the round ligaments on both sides, and then you get a little bit of wiggle room laterally. You can push the uterus up a little bit, and then you get that golden view. You know that view where you look into the posterior cul-de-sac and you can see
I'm done.
Your cup? Right. Yeah.
Case is over.
Right.
Case is over. Yeah. What we're talking about is, when you've got the anterior posterior peritoneum open and you've got a view of that, because a lot of times the bigger pathology, it will lift the cervix up. So it's already off the sigmoid, it's off the colon. So you've got the golden view. Yeah. That like, what's the mind the gap, right? The circle with the line through it. So I've got my uterines here, and I've got my uterines here, my colpotomy cup here. I'm done. The case is over. But I found that, in a normal size uterus, a lot of times with a straight stick TLH, I would sort of go contralateral. I'd go across and get the uterovarians from the right side of the patient. I would get the left uterovarians and have the resident get my uterovarians on my side. But with a big uterus, it's really hard to start on the uterovarians because just the angles. Because if you place your ports too high, like you're saying, you go pretty high laterally, That can pose a problem closing the cuff, though. So you got to kind of, unless you're adding, high and low ports, which is fine. But if you're going to just commit to like 4 ports, plus the, polymers if needed, keeping those ports a little bit lower for the cuff closure. What's your setup? How do you set up? Are you ipsilateral?
I go all over. It's a teaching programs with the fellows. I like to make sure that they are comfortable with everything.
Oh, stop it.
I'm sorry.
It's too much work.
I'm sorry. But ipsilateral, contralateral, suprapubic, we'll do the whole mix.
You fellas are so lucky. My poor residents, like, we're doing it this way, and this is how we're always going to do it. But I have found that if you get the rounds first, like you said, it opens it up a little bit, open up the broad ligament. You can make a little window, which I usually think about making a window for getting your IP for taking ovaries. But even if you're leaving them behind, making that window allows you, again, it's going to be lifted up off the pelvic back wall. So you're going to have space. Once you make that window in the posterior peritoneum, you've got a straight shot to your uterivarians, almost from bottom up on your side. So you can kind of come up the uterus that way and get your uterivarians that way. And once you've got your rounds and uterivarians, gravity helps you, I think, as much as anything. What's your angle on your bed, on your T-berg?
I try not to hang on to any number because I don't want, the conversation anesthesiologist is a little more, as opposed to let's go to 17 degrees and let's just go from there. Works both ways. Sometimes you can start off and you don't have to be in steep Trendelenburg, and then I'll gradually increase. It just kind of depends.
No way. 17? Stop it.
What do you use?
It's 26. Get them on their heads. Obviously, we can come back, but to me, it's just like let gravity be your friend. Put them on their heads. Uterus falls down. It's pulling up. It's doing all the work for you. I mean, I'm sure 17 is probably pretty similar too, but 26 feels steep. And I was the first one using the egg crate foam when I first came to my institution. So I put them steep, and they would, and because I didn't want to use shoulder braces because risk of shoulder brachial plexus injury, and the grief I got, especially from my anesthesia colleagues, they're like, "You are out of your mind." I said, get a marker and put a mark on the bed where their shoulder is, and if they move, you come find me. We've since gotten that pink pad. Is that what you guys use?
That's what we use for everyone.
I hate spending money, but my goodness, is that a nice piece of equipment? It doesn't budge if you get them in the right spot. Get the butt off the edge, hang the butt cheeks off the bed, support their sacrum, and they're locked in. So yeah, to me, steep is great because it just pulls everything away that I don't want in my view. But like you said, once you've got the upper pedicles, that's the biggest thing. Everything's up out of the way. It starts to look like a normal uterus for the most part. One of the big challenges I've seen, or I experienced, especially with straight stick cases, is you can't get over the uterus, right? So you can, I stand on the right side of the patient. I'm sure you stand everywhere, but I don't. I stand on the patient's right. And if I'm going to try to help out, reaching across the uterus is a challenge, right? So how do you overcome those kinds of things?
Yeah, I'll go with a midline port, whether it's suprapubic or umbilical, and then you can kind of do most of the dissection midline and ipsilateral port.
Now, I'm definitely an ipsilateral person, but I also had a partner who used the suprapubic diamond arrangement. And I do feel like for the really big path, it's actually super nice for exactly what you're saying. Is it's hard to get up and over the uterus if I would to assist you if both of my hands are on the right side of the patient. If you're working on the left, it's hard for me to help you. It's also, those cases are one of the few instances where I use a tenaculum. I almost never use a tenaculum. Do you use them a lot?
I do not. I may use it once I secure the uterine vessels and all the vasculature, but I'll tell you, I failed to mention this earlier. My biggest friend is the flex tip scope. I use a 5-flex scope for every case.
What do you mean flex tip? Like it curves around?
Yeah, picture a sigmoidoscope almost, right? Where you can flex the tip of it.
How much money you guys got up at Northwell?
I mean, what? It just... I put my foot down. Do you use this for every case? This is what I want. And they just made it, and that's not true. They had it there. I use it for every single case. And once you get over the learning curve of driving that scope where you can flex it, right? So the tip goes up, down, left, right.
It's rigid all the way to the end, though. Yeah.
Rigid to the last maybe 3 centimeters.
I'm sure your residents love that.
They appreciate it because not everybody uses it. So when we do get in there with a large uterus, they can appreciate getting around the corners to see down into the pelvis.
I do think I use a 0 for basically every case with the exception of the big giant cases because you just can't see around the corner. So whether it's a flex scope or whether just a 30-degree scope, that is the time when I feel like the angle helps. It helps posteriorly for sure. I think it really helps anteriorly because a lot of times if you have big anterior bulk, just getting the bladder flap down. But again, like it's every case, right? Lateral to medial. That's the move. You find your uterines, you leave them alone, you kind of skip over and sweep everything up and down. Nothing more important in a case to me than skeletonizing the uterines. Are you doing that every time? Every time. Every single time. I got it. Do you usually start posterior or anterior for your broad?
Usually start anterior. Yeah, get the bladder flap down, get the bladder out of the way, and then I can feel a little bit more comfortable about addressing the uterines.
I've started doing the opposite. I think I learned anterior first, and then dealing with a lot of anterior pathology, going posterior and realizing that gives me everything. So posterior peritoneum, you find the uterus and just hop right over, a little push and spread on the anterior cup, no cutting, no energy, just push your tips down. If they've had 5 C-sections, I don't care. We're typically not incorporating the uterines in our closure, at least not at that level of our cesarean scars anyway. So push, spread, and you've got your uterines isolated in like 30 seconds, like over that cup. And then you can mess with the bladder all you want. I just think it's also easier to see. I don't care about getting all the way around the peritoneum posteriorly. So to me, it seems to just fall away more easily. But again, it's all the same. It's just whatever you're used to doing. And then once you got the bladder flap and the cup isolated, then it's just a regular hyst. Now, except for the fact that these uterines oftentimes are bigger than your thumb, right? So like, what's your energy source? What are you using for most? Are you using the same energy source regardless of uterine size?
Pretty much. I'm using an advanced bipolar, using the ligature. I'll tell you, I like the Maryland tip ligature. I like that little curve at the end to help with the dissection, adjust how much tissue you have. Blunt is fine, but yeah, I use the Maryland. And
same thing. I had the blunt. They brought the Maryland. I'm like, that's a little bit nicer, but whatever. Yeah, I mean, they both work. But I also like that the bottom jaw doesn't move and the top does, right? I like instead of both moving, I like for dissection purposes.
My challenge to you is next time you get a chance, use that Maryland tip on the patient's left side, because when you do the bladder flap,
it curves the wrong way.
Exactly.
That's why I never go over there. And just watch the residents struggle and go, you guys are terrible. And then I give myself 2 hands and the right curve and go, see how easy it is? Oh, believe me, I know what I'm doing. It's not my first day. Yeah, no, it's definitely different. Okay, so we see a lot of our colleagues at AGL posting their videos of opening up the sidewall and getting the uterine at its origin. How often we've talked about this ad nauseum in our long walks, but are you doing this? Are you not doing it?
I do it from time to time. I think it's an important skill to have. And again, with my fellows, with the second-year fellows, I often go into the sidewall. I'll secure the uterine
with energy or clips?
I use energy to keep it simple. I'm not transecting it. I'm just using that Maryland tip ligature to seal it and then slowly back away.
It's one of those things that I think initially I was just so scared of, and then the more you do your uterolysis and you just go boop, 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 and just push it away and go, oh, it's right there in front of me. Like, it's actually less scary to me the more uterolysis that I do, the more I know where the ureter is, the more I know where the vessels are. It becomes far less scary because I know where stuff is now instead of it's all like kind of hidden in the sidewall. And that was something that I did in fellowship. We didn't do it as much as I think people are doing it these days. At least in my fellowship, it was something that I got a lot more comfortable in doing throughout my career, but also I had a partner, Peter Mavilla, who's a great surgeon. I mean, I have a great partner and surgeon now, and George Thomas, but Peter came first and it's nice to have a different way of doing things. And how many people are in your group?
We have nine faculty attendings.
9 MIGs?
Correct. Mm-hmm.
Good gravy. All in your group, or is it different hospitals? Or
they're in different hospitals. There's a little bit of overlap. Some of us go to multiple hospitals.
How many fellows do you have?
We have 3 fellows.
So 2 and 1. 9. That's amazing. Do you ever operate with your colleagues? Is there a situation when you guys operate together?
It's rare, and it's usually because something's not ideal.
Yeah, you guys probably all train different places, or a lot of different places anyway.
Yes and no. I think we now try to celebrate some of the variety and diversity, and the fellows appreciate it. But like so many other programs, we have fellows who just kind of come up through residency, they stay for fellowship, and then we love them, and we hire them.
And they're so well trained.
They are trained with the best. So
that's right.
So yeah, but no, it's great to have some variety. We have a couple of faculty members who have come from other places, and they use different instruments. They stand in different places, and the fellows really do appreciate that variety.
I'll be honest, I get the uterines at the origin like once in a blue moon. And it's not that I can't. I think if they're looking right at me, if I can get everything set up in a way that they're just staring right at me, make a big old wide fat pedicle and just march, like a shirt up and down until I have about, a centimeter, 2 centimeters of seal. And if it retracts, I've got, and I also take my uterines a little bit above the ring and, like they'll retract back, and then I've got room for air. But in general, like, smart bipolar devices know what they're doing. And even like bigger, centimeter plus vessels, which they're probably not supposed to be using, but 7 millimeters? What do they tell you?
I think that's what they're saying. Yeah.
But yeah, I mean, that's it, right? I mean, I think the biggest problem we have oftentimes is back bleeding, and also something I've learned in my years, just wait. Eventually, if you've got your uterines secured and it's dark blood coming out and it's filling up the pelvis and you start to panic, if you're confident that it's back bleeding, just wait. It will stop. And I think one of my only early conversions was I couldn't see, and then we opened and the uterus had bled out and it was totally fine. But in the moment you're going, oh no, I got to do what's right, what's safe. And that's always the answer. But you go, I wish I could have had that one back. I know we all have those, but.
I'll tell you something about the sidewall going to get the uterines. We have a decent number of Jehovah's Witness patients who would not accept blood products. And sure, we'll have the cell salvage system set up, but there's something about going in for the large uterus and really just sealing those uterines. You can turn to the anesthesiologist and you can say, chances are we're good now.
That's nice. We had a lot of patients who wouldn't accept products in residency, and we did a bunch of big abdominal myomectomies. And it was just like, go. It was like a speed surgery because that's all you had.
Yeah, right.
But with hysts, you can be a bit more specific about your control of blood supply in that sense. So we've got our uterines, we've skeletonized our uterines, we've taken them, we've now got our colpotomy cup is in, and now we have a good look at our cervicovaginal junction where we're going to make our colpotomy. What are you using for colpotomy?
So I'll use just a simple monopolar hook. It's free. It's on the table. It's on the set. Does its job. My setting is usually 40 and 30. Cut to coag.
All right, so we're using cut on the cuff?
Cut on 80% of the cuff. I use coag at the corners, in like 3 and 9.
Yeah, no, that's great. I think I'm just using cutting, and I'll kind of have the dab of monopolar of coag if I need it. But yeah, I don't need the fancier instrument with the hook. I've got a free one. It's on the set every single time. One of the things that can be tougher in these cases is uterine manipulation, but especially the vaginal, lifting it up enough to get posteriorly. So what are your tricks there?
So number one is that's where I might do the supracervical hysterectomy. I've sealed the uterines, got them low enough, then I'll use that monopolar hook and I'll cut off the upper part of the uterus. So you went from 1,500 grams to about 30, and I'll readjust my uterine manipulator, get my cup where I want it, and then it's like any other uterus at that point, just doing the colpotomy.
I've done it less recently because the other trick I've started doing is I'll make my anterior colpotomy and then I'll take the manipulator out of the uterines, because oftentimes that's what's holding you up. You can't lift it up because you're actually holding yourself down. So take the manipulator out, especially through a suprapubic. Take a tenaculum, grab the cervix, and just lift straight up, and then you can go do right, because all you have left is just the posterior vaginal wall, and you see the cervix. So you can it's like a perfect right angle. So just grab your cervix, lift straight up, and run across the bottom, and you've lifted it up way up off the pelvic sidewall, safely away from the sigmoid. And it was the first time I did that. I took it up, I'm like, I was in my own way. I was keeping myself from seeing what I needed to see. So that was something that I started doing, and now it's like, it's actually easier than the supracervical. Just take it out and grab the cervix and lift it up, and it'll work. And then morcellation, we can certainly talk about. I assume we're all doing probably. Is anyone using mechanical morcellators anymore that you know of?
I've heard of whispers out in the communities,
in dark corners.
Yeah. We don't talk about them out loud.
I feel like are there bags now where you can do it? I don't even know anymore, but
there are bags. I haven't tried one, haven't used one. You know why? Because we switched over and we got pretty comfortable doing it.
And it's actually really nice, and I don't miss it one bit. And so you're doing the tissue extraction bag. Is it applied? Is that what you're using?
I use applied, yeah, the 14 or the 17.
17, I think the limit, my experience, is like the 2,500 gram uterus is about, and you just did one, you said it was like 27. Did it fit in the bag?
No, it did not.
Yeah, so we found it, I think. It was like 2560 or something, and it just barely squeezed in the bag. And then, you have about an inch and a half of collar of that thing that'll fit up through your incision. So where are you making your incision to morcellate your contained morcellation site? What's your approach? Because we were in Vegas, we talked a little bit about this, but most of the videos we saw were umbilical incisions. And that's kind of traditionally, I think, what people were doing, at least in the courses and those things. What are you doing?
So first choice is the vagina. I still go back in my day, we took it out of and so that's where I'll try. And if it works, that's what I'll do. Second option will depend on prior surgery. If somebody's had a prior C-section or two and they have that fan and seal incision, I might just use that portion of it.
That's my go-to. I mean, yeah, vaginally for sure. And I don't tell them, because you're not going to really know, in my opinion, until you do the hyst, look at the cuff. It's like, how much mobility is there? How much access is there? If you get in there and it's like a mile away, it's just not happening.
Mm-hmm.
But fan and seal to me is such a great incision. I've talked about it on the show a bunch, but mini lap fan and seal, 3 or 4 centimeters, and they don't complain much. The people hate belly button incisions. They hate, and the hernia rates are super high.
Right. That's what I worry about.
Yeah, like my hernia surgery colleagues would tell me it's like 33%. A lot of these bigger incisions like that, the hernia rates, and they're like, yeah, do it, because they'll come see me and I'll get to fix it. But they're like, yeah, it's not great. It's not great.
Yeah, and you use that big one, that 17 bag. I think it comes with an Alexis wound retractor.
I love that, by the way. So tell me your setup for that. Once you've got you put the bag in the belly, you put the uterus in the bag, bring the opening back out, then what?
And then I'll take that Alexis wound retractor, and if for a very large uterus, I'll put that Alexis inside the bag and open it. If it's not huge, I'll go the other way, and I'll bring the bag up through the center of that Alexis wound retractor, and I'll tell you about why later. But either way.
Wait, say that again.
So either I will take the edges of the bag and evert the edges, put the Alexis wound retractor into the bag so that it opens up down and it's entirely within the bag, and then I'll just morcellate that way.
Where do you put the wound retractor?
Alternatively, I'll bring the edges of the bag together, put the Alexis wound retractor on the outside of the bag so that you have to force the Alexis wound retractor down into the peritoneum.
You talking about the plastic protector or the other Alexis?
No, the other Alexis.
So you put it on the outside of the bag. And what about the wound protector? Where does that go?
I usually don't use it.
I've actually started using it. Vaginally, it's awesome.
Yes, it is.
Vaginally, because they have 2 of them now. They have the vaginal and they have the abdominal. The vaginal one works super well. Very good design. I don't work for them. I've never worked for them, but it's a nice design. Engineers, golf clap. Good job, guys. I'm trying to remember who taught me, but I think Peter may have been the one that showed me that. He's full of good ideas, but big bag, uterus in the bag, opening of the big bag, and then put the wound retractor in, and then put the Alexis inside that, and it really pushes out very sort of evenly circumferentially out. And the other thing is trying not to cut the bag. That's and I don't cut it deep. I'm not worried about spilling tissue, but you got to be real careful about, because then it just falls apart, and then you're getting new Alexis and stuff. But yeah, and that's the biggest thing. I think that's the part that I just do for my residents because it's so boring and they just hate it, and so it's let's just get it over with. At that point, we're exhausted. We've just tackled this massive uterus. It's oh my gosh, I'm exhausted. Can we just morcellate this before, dinner time? Can we just go? I'm I'm ready. I'm just in my mind, I'm so ready for this automatic morcellator, because that's the part of the case where mentally I'm ready to be out of there, and I still got a lot of work left to do. But I love closing. If I have to close a fascial incision, I want to close a fan and steel, not an umbilical incision. That's the other big thing for me. I can see my fascia. I know what I'm getting. I know what I'm closing. And then, are you closing cuff before you morcellate if you're not taking it out vaginally?
I've been going back and forth with that. In general, yes. I just think it's nice practice because the vagina is still going to be a little vascular, and if you don't close it, there's nothing to stop it from oozing. And I feel like if you can avoid any blood loss, then it's a nice thing to do. So I'll just close it right there.
The other reason I do the same thing. The other reason I do that is because I want to look at it later. I'm gonna come back 30 minutes later after morcellation and go, is it still dry?
Yeah,
because we don't always get that long look. Like we don't get to come back and go, let's just take a look at that cup one more time. Like it's had, if whatever it's gonna do, it's done. All right. So close the cuff, close fascia, Foley catheter. Are we doing cysto every time?
Every time.
Every time. Using the same flexible scope or using a cystoscope?
No, I'm using a cystoscope. Usually it's a 17 French 70-degree scope.
Yeah. I'm down for those guys who are just using the same scope. Like it's cool, like the backfill and all that. I'm just like, I just haven't made that leap yet. I know the data is pretty good, that it's clean, but I haven't done it yet. And always cysto. What do you give them? Peridium?
I usually use fluorescein.
Do pre-op peridium?
Yeah. Mm-hmm.
And then it doesn't hurt to pee after too. That's like one little benefit, and it's super cheap. And then sending home, keeping. What are you doing for discharge?
Yeah, sending home. They usually go to the recovery room for, honestly, I think it's like 2 or 3 hours, and then they go home.
Do you make them wait to pee?
Yes, we do.
I do too, and I feel like Kelly Wright's going to like yell at me, but I feel like there's people out there like the data doesn't support it. So we're actually looking at doing that now, just like getting the entire GYN surgery group together and be like, all right, what's the plan? Because these poor post-op nurses are like, dude, just give me one plan. Please stop like changing it, like who the surgeon is. Like it's all the same surgery. Just so that's what I'm working with. One of my colleagues, who's a generalist, who's also interested in this kind of stuff, is like, let's do it together, and it'll be a nice, get a resident involved. It'll be a nice QI project, and just like, let's just do one way. Like at least the peri-op stuff in the OR, all bets are off. But at the very least, we all do it for the most part the same way. But at least perioperatively, like our nurses who are overwhelmed and overworked already as it is, like let's just make it simple. So I forgot to ask you, Lupron. Do you ever do anything like that with any regularity?
Not regularly, but the patient who comes in, it's usually a teacher, and I see her.
She's got a window in the summer,
spring break, and she's like, I'm free tomorrow. I'm like, yeah, tomorrow's not going to work, but there will be an opportunity for summer break. So for 3 months, large uterus, I'll put her on Lupron. Sure.
I feel like the time it takes us to get Lupron, it's like time for surgery sometimes, like with the insurances and things like that. So maybe it's just we need to try again. But the other thing is, if it's not going to change my approach, if it was going to change my approach, then yes. It's not going to change my approach. I probably could use it more, but I don't.
Yeah, I've been impressed with how the effects it has on size of the uterus. I'll bring them back in 2 weeks before surgery, do another exam, and sometimes I'm really surprised. And then at the time of surgery, when you see that uterus, it looks similar to that uterus that's had the uterine artery embolization, so the blood loss is a little bit less.
And we do a lot of those. Those are a little less fun because then it's like the uterus is like leather. I mean, that's like, it's morcellating those. You need like a hacksaw sometimes because they're calcified. But all right, dude, we did it. That was fun. Anything else you want to?
No, that was a good time. I will tell you, just like we started the conversation, day 1 out of residency or fellowship, jumping on a 32-week size uterus, probably don't need to do that.
Don't do it. Oh yeah, we've talked about it a bunch. Be smart.
Be smart. Take it easy. It'll come to you in the years after, and then you'll feel comfortable with it, as opposed to scaring the bejesus out of yourself on day 1.
Yeah, don't be stupid. I totally agree with that. And the last thing I want to say is to our friend Karen, we have to do a little, I'm going to hold the phone up here to do a little selfie, say cheese.
We do love Karen.
All right, I'm going to send her a picture because
that's great.
Because every time we hang out, this is a friend who works with me who we were residents, right? Together?
Correct. Yep.
So, and she's one of the best people we know. She and her whole family are wonderful. But we'll have to get her on the show and talk about diabetes. That's her big thing too. So anyway, all right. Much love to you, buddy. I think the world of you. Thanks so much for coming on the show. The best to you and your family. And we'll see you in New Orleans.
Yep, I'll be there. I'll see you there. We're going for a
walk. Bring your
walk.
walking shoes.
Yep, got to get some beignets.
Just got to walk them off. I don't know if we can walk far enough, but we'll try. All right. Good to see you, man. Thanks for coming on.
Thank you. Take care.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.